Good evening, everyone. I am Dr. Vishwa. I am the consultant emergency medicine in Yashoda Hospitals, Secunderabad. I thank you all for taking your time to join us today for the webinar. I also have here today with me Dr. Shameem and team from KIMS Trivandrum and Dr. Ramyajit and team from Narayana Hrudayalaya, Kolkata. Today, we are going to discuss three important clinical trials on IV crystalloids in acute care settings: SALT-TD trial, SMART trial, and BASICS trial. Feel free to drop your questions. Let's make it a discussion rather than a boring topic. The whole point of this weekly webinars is to encourage our young residents to develop research temper. Now I request Dr. Shahana, our second year resident, to proceed with the presentation, the SALT-TD study. Come, Shahana.
Good evening, everybody. Today we'll be discussing the SALT-TD trial. Basically, it is the balanced crystalloids versus saline in non-critically ill adults. Here, the clinical question that we raise here is whether to administer balanced solution or normal saline in non-critically ill patients admitted to ED, and will that reduce the hospital free days? Over 1 million patients per day are administered IV fluids in hospital. Despite this frequency of administration of IV fluids, we are not very clear about the choice of the IV fluids that we are supposed to choose. However, there are previous studies which shows that the synthetic colloids are harmful to the patients rather than crystalloids. So thereby, chest studies have established the safety of IV crystalloids. 0.9% sodium chloride, when administered in large quantities, can cause hyperchloremic acidosis. Along with that, it can account for AKI or reduced renal blood flow. The administration of a balanced salt solution may attenuate the postulated risk associated with the administration of normal saline. So here the SALT-TD trial is a single-centered, randomized, open-label, multiple crossover study. It is a pragmatic study design with an intention to treat analysis. A multivariable proportional odds model was used to assess the primary outcome of hospital free days. Multivariable logistic regression analysis was performed for secondary outcome of major adverse kidney events within 30 days, which included AKI or renal replacement therapy requirement, irrespective adjusting to the day for age, sex, race, admitting the patient, and days associated with the trial. The type of crystalloid was assigned every month. The ER physician would decide whether to give a plasmolite or a ringer lactate solution on the month of month of balanced solution, and on alternate months, normal saline was administered. The assignment for the first month was generated by computerized random sampling. The assignment was thereafter sequential for the following 16 months, alternating every month between 0.9% sodium chloride and balanced salt solution. 14,000 patients would provide 90% power to detect a difference of 0.5 hospital free days between groups with type 1 error rates of 0.05. The setting, it was a single-centered study happening at the Vanderbilt Hospital in USA, which received about 75,000 ED admissions in a year. And the patients were recruited from Jan 1st of 2016 to April 30th of 2017. Population, the inclusion criteria included the patient over 18 years of age who had received at least 500 ml of IV isotonic saline in ED, and those who were admitted in a non-ICU settings. Exclusion, who received patients who received less than 500 ml of solution was excluded from the study, and the patients those who were admitted into ICU were recruited into the SMART trial. 49 patients received IV fluids, out of which 3,689 received less than 500 ml, and they were excluded from the study. 2,913 patients were admitted to ICU, and they were recruited to the SMART study. Final sample size was 13,347. Patients were well matched at baseline. So baseline characteristics were taken and randomization was done based on their features, including age, sex, race, and other IP admissions, serum creat values, RFTs. Interventions, basically, the most balanced crystalloid administered was lactated ringer or ringer lactate with remainder as plasmolite A. If patient had the relative contraindication of hyperkalemia or traumatic brain injury, then NS could be used as preferred solution instead of balanced solutions. 83.8% received only the assigned crystalloids in ED, and 4.8 did not receive any assigned crystalloids. Total crystalloids received in ED, that the median balanced crystalloid was about 1089 ml. Again, this talks about the mean balance solution or volume that was administered to the patient. 0.9 saline for IV therapy. 92.8% patients received only the assigned crystalloids in ED, and 1.2% did not receive any assigned crystalloids. The total crystalloids received in ED, the mean was about 1597 ml. All irrespective of the condition of the patient was given with IV fluids, and rest of the parameters, as in whether they're treated, whether to treat with crystalloids or IV fluid was the alone decision taken regarding the patients. All other conditions were treated according to the patient's situation and status. Provider had the option of using off-protocol crystalloids if they believed an alternative was specifically indicated. The primary outcome, there was no difference in the number of hospital-free days between patients in balanced crystalloids and saline groups. That is, median was 25 days in a group. Adjusted odds ratio with balanced crystalloids were about 0.98 and 95% confidence interval. Hospital-free days were similar for patients in balanced crystalloids and saline groups across a broad range of baseline characters. This chart basically represents the electrolyte variation after administration of saline over time in ED. You can see that when saline is administered, the sodium and chloride values were elevated, whereas when balanced solutions are given, electrolyte imbalances are relatively less. Again, there is no much difference. There is no much difference when it comes to blood urea, nitrogen, creatinine, or potassium values, where bicarb will be elevated after administration of lactated ringer. Now coming to the median hospital-free days, which was expected to be the primary outcome, there was no much difference in the crystalloid group, means the balanced solution group or the normal saline group. However, the MAKE, that is major adverse kidney events within 30 days, was less in patients administered balanced solution rather than with normal saline. The secondary outcome, patient in balanced crystalloid group had significantly lower incidence of major adverse kidney events within 30 days than those in the saline group. Again, MAKE 30 were a composite of death from any cause, new renal replacement therapy, or persistent renal dysfunction. The largest benefit in reduction of MAKE was observed in patients with pre-existing renal conditions or with patients in hyperchloremia. 1.4% in balanced crystalloids versus 1.6% in saline group. There was no significant hospital difference in the in-hospital death of this patient. Again, this came to the coming to the chart. This is a forest plot showing the odds ratio in patients who are administered balanced solution and those administered normal saline. You can see that the AKI or major adverse events are reduced or lesser when administered with balanced solution rather than normal saline. Finally, the conclusion that we can make from this study is that the number of hospital-free days did not differ between patients assigned with balanced crystalloids or normal saline. However, the secondary outcome varied. The strength of the study, study assessed or addressed an intervention that is applied to millions of patients around the world every day. So it has the importance and relevance for routine clinical practices. The pragmatic design meant that very few patients were excluded from the study. More than 85% of the patients received the allocated interventions, and the primary outcome was patient-centered. Clear difference in patient electrolyte concentration, as in sodium chloride and bicarb, were observed between the two fluid arm groups. The randomized trial design resulted in minimal baseline imbalance between the groups. This was further enhanced by a pre-planned multivariable logistic regression analysis of several baseline characteristics for in-hospital death and major adverse kidney events. The high quality of data analysis means that the result can be used to generate hypotheses for future studies. Coming to the weakness of the study, the difference in the secondary endpoint of major adverse kidney events was largely driven by difference in the surrogate outcome measures, as in serum creatinine. It is unclear whether this would translate to the benefit of the patient. As in here, when we assess the benefit or the secondary outcome coming out of a balanced crystalloid, we were relying on lab parameters as serum creatinine. The relevance of projecting this onto the patient outcome or prognosis is not very clear. That can be pointed out as one weakness of the study. The outcome data was gained from a retrospective analysis of hospital medical records. The single center study design limits external validity, particularly to the non-US population. The type of fluid administered in ED was unblinded, so the physician bias in and how much IV fluid to be given could have occurred. No evaluation was made of fluid administration following hospital admission. It is therefore difficult to draw too many conclusions about the impact of 1 liter of fluid given in ED. Fewer patients in balanced salt solution received the allocated study fluid versus 92.8% of the patient allocated received saline group. It is unclear what proportion of patients attending the ED received IV fluids. The length of ED stay was also not documented, and these results can also, whether we are not sure whether these results can be generalized with an emergency across access target. Coming to the conclusion from the study, this study needs to be replicated in multi-centers randomized control trial before the conclusions can be drawn about the proposed deleterious effect of NS administration. Until then, we'll have equipoise on whether to administer a balanced salt solution or saline to the patients unless there are good clinical reasons such as traumatic brain injury or hyperkalemia for choosing one over the other. These are the references of the study. Yeah, anybody has any queries?
Hannah, I have a query. Okay. How did they get the consent from the patients?
The hospital had waived off the consent for the patient because the study had a intent to treat study. So they had already waived off consent. The ethics committee
They
of the
waived
study.
the informed consent from the
study for the study.
That's a really good point. That's why they could able to recruit 14,000 people, so much of the population, which rather increased the strength of the study. Okay.
Sample size of the study was thereby increased.
Any other queries?
The chat box is open in case if anyone has any questions, you can post
drop in the chat box. Shall we move on to next topic? I think Dr. Naveen, we can move on to next topic.
Okay.
Yeah.
Next is from Kim's, right?
Kim's team will be presenting basics trial.
Dr. Sneha, we have given slide control to you. Can you try changing slides?
Yeah, thank you, Dr. Vishwa. I'm Dr. Shameem here. Am I audible?
Yes, please.
Yes.
Yeah. So we'll go ahead with the second presentation. That is from Dr. Sneha from Kim's Health Trivandrum. So I would like to invite Dr. Sneha for the second presentation. Thank you.
Thank you, sir. Good evening, one and all. I'm here to present basic trial before you in the journal club test. The slide is not on. So basic trial, that is the balanced solution versus saline intensive care study, which is a randomized clinical trial. We know that every day, thousands of people receive IV fluid in ICU, which is the cornerstone of hemodynamic management. There are fluids as well as colloids that the patient receives, and even small benefits in the reduction of mortality can have important population effects. And emerging evidence suggests that.
Sneha, can I interfere? Yeah, can you just check your mic? I think it's not audible. That is what the chat box says.
Sir, is it audible?
Yeah, I think it's audible now.
Keep your microphone closer, please.
Is it audible now? Hello? Is it audible now?
It is audible, but you are not very clear. Do you have an headphone that you can use an headphone?
Sir, I'm using headphone.
You're using it, so then remove one. Then I think it will be better.
Is that like Bluetooth wireless ones?
Yeah, I think so, Dr. Naveen.
Do you have a microphone on the laptop?
Sneha, are you there?
Sir, is it audible now, sir?
Yes, better. Definitely better.
Okay, sir, thank you. So I'm here to present before you the basics trial, which is the study that compares the effect of balanced crystalloids with normal saline in ICU patients. We know that every day in ICU, thousands of patients receive IV fluids, that is either crystalloids or colloids. And this is to restore the intravascular volume as well as for better hemodynamic perfusion of the patients. So even small benefits in the reduction of mortality and organ failure could have important population effects. And there are many studies that shows that normal saline, which is 0.9% sodium chloride, can cause hyperchloremic metabolic acidosis increase in pro-inflammatory cytokines, decreased kidney perfusion, acute kidney injury, and mortality. So there are many trials that compare either crystalloids with colloids, there are many trials that compare various crystalloids also. So this study was conducted. The study is a double-blinded study, which is factorial randomized clinical trial that is conducted in 75 ICUs in Brazil. The data was collected from 29th May 2017 to 2nd March 2020, and the study was published in Journal of American Medical Association in 2021. The design is it's randomized in 1:1:1:1 ratio. That is, they're comparing the balanced solution, that is plasmolide 148, with 0.9% sodium chloride, as well as they were comparing the rate of administration, whether there is any difference when the patients receive IV fluid at 333 milliliter per hour and 999 milliliter per hour. The randomization was done via an online software, and those involved in the patient care were blinded to fluid type, but not to the rate of administration. The fluids were labeled from A to F, and they contained 500 ml of fluid. The study fluid was 500 ml in each study fluid. And the data and protocol adherence was checked on days 1, 2, 3, and 7. And the patients were followed up by a phone call at day 90 to assess whether the vital status are okay and there was any need for RRT. The power calculations was the planned sample size was 11,000, and they assumed that there was no interaction between the fluid type and the speed of administration. There was pre-specified secondary and tertiary outcomes, and subgroups were also specified. The informed consent was obtained from the patient, and appropriate ethical approval was gained. The clinical questions that addressed was, in adult ICU patients, does the use of a balanced crystalloid compared to 0.9% saline reduce the 90-day all-cause mortality? The other question that was addressed was the infusion at a slow rate compared to fast rate reduced 90-day all-cause mortality. So two questions were addressed in this trial. Includes the patients who were included. The inclusion criteria was the patients who got admitted to ICU with they should have either some signs of hypoperfusion or they should have some fluid responsiveness signs also. And they should not be discharged for 48 hours after admission. And there should be at least one risk factors for acute kidney injury. That is age greater than 65 years. There is some signs of hypotension like mean arterial pressure less than 65 millimeters of mercury, or systolic BP less than 90 millimeters of mercury, or there is sepsis. There is need for mechanical ventilation for 28 days. There is signs of oliguria. There is raised creatinine level, cirrhosis, or acute liver failure. The patients who were excluded were the patients who are less than 18 years, the patients who required RRT, or expectation to require renal replacement therapy within 6 hours, and the patients who had severe electrolyte disturbances, that is sodium less than 120 or greater than 160 or potassium greater than 5.5. This hyperkalemia exclusionary criteria was later removed after randomization, and these patients were included in study population. And the other patients who were excluded were the death expected within the next 24 hours, and suspected or confirmed brain death patients, and the patients who were on palliative care. So when we look at the study population, 11,052 patients were randomized, and equal number of patients were allotted for each group. That is around 2,750 patients were allotted for normal saline balance and this balanced crystalloids group. As well as among them, they received either at 333 milliliter per hour fluid rate or at 999 milliliter per hour fluid rate. And some people got lost to follow up. And then at last, 5,230 patients were included in the primary outcome analysis group. in the balance control group, and 5,290 patients were allotted in the included in the primary outcome when they compared this fluid rate. So the randomization was done by a central web-based automated randomization system that was available 24 hours per day, and the list was generated with online software using random permuted block size of 12. The intervention was using of a balanced crystalloid, that is plasma light 148, and the patients should have some signs of fluid responsiveness, and they should need at least one fluid challenge or maintenance fluid or drug greater than 100 ml. And the intervention is giving a slower rate of infusion, that is 333 ml per hour if fluid bolus were required. And there was triple binding. Neither the patients or the physicians or the assessor knows what fluid is being given to the patient. The control group was the user, the patients where NS was used, and the patients who got fluid administration at a rate of 999 milliliter per hour. They collected some additional data also, that is Apache score and SOFA score, as well as KDI-GO score, and they assessed whether the patients needed any organ support or mechanical ventilation. If they needed any vasopressor support, then kidney replacement therapy, admission, and they assessed what admission type it was, the administration of fluids within the 24 hours before ICU admission, and the need for renal replacement therapy. And they also noted whether any serious adverse events were there during the treatment. The power analysis and sample size calculation, they assumed 35% mortality within 90 days in the control group, and thus they calculated sample sizes 11,000. 89% power to detect hazard ratio for mortality of 0.9 or less with an alpha of 0.05. The primary outcome, 90-day survival, was analyzed using mixed effects Cox population hazards models, considering enrolling sites as a random variable, and adjusting for age, baseline SOFA score, and the type of admission. RRT, the renal replacement therapy, was analyzed using mixed poison model, and they assumed that there is no connection between the fluid type as well as the fluid rate of administration. All analysis were performed using our software version 4.03. Interim analysis was done when the patient's sample size got finished at 25%, 50%, and 75% of the cohort. The stopping rule of safety was p-value less than 0.001 for 90-day mortality. Next, the outcomes. The primary outcome was 90-day survival, and the secondary outcome is the need for renal replacement therapy up to 90 days after enrollment, the occurrence of AKI defined as KDIGO stage 2 or 3 evaluated at day 3 and 7, and SOFA score assessed both as a continuous total value and as its individual components, that is cardiovascular, neurological, coagulation, hepatic, and respiratory at day 3 and 7. The outcome, the tertiary outcome was ICU and hospital mortality and ICU and hospital length of stay. So when we come to the results, we can see that the number of patients, age, sex, admission type, everything was comparable. The results are comparable between the balanced solution as well as the saline solution. The Apache score, the median value was 12 for balanced as well as the saline solution. And SOFA score, the median value was 4. And they also noted the KDIGO stage, sepsis, traumatic brain injury, hypotension, serum creatinine level, then time from ICU admission to randomization, and that median value was 1. So like that they analyzed. And other things they analyzed was the administration of balanced solution within the 24 hours before enroll. So they analyzed whether the patients got balanced solution or normal saline before they got enrolled into the study. That before randomization, if they got any IV crystalloids or any other fluids also, they also analyzed that. And they analyzed if they got any other solution within 24 hours before and after the enrollment into the study. So this is the cumulative mortality graph they did for this, they got after the study. We can see that the cumulative mortality increase as the days pass, and there is a similarity between the mortality of normal saline group as well as the balanced solutions. Balanced solution is plasmolide 148. This is the chart that plots the amount of fluid that the patients got on various days. On day 1, we can, this light gray color is this study fluid, that is the patient got after labeling. The dark fluid is open crystalloid, that is any study, the fluids that is similar to study fluid, but not the study fluid. And other fluids means any colloid or something. So we can see that the patients got both study fluid as well as some other fluids also during all these days, and we can see that the amount of fluid they they were administered also reduced when the days pass by. The other results was 48% of patients were admitted after elective surgery, and majority of the randomization was happened on the first day of admission, and 68% got crystalloid bolus, and 45% got 1 liter of bolus. And among the patients, 44% required mechanical ventilation, and the median value of fluid administration was 1.5 liters, and that was obtained, that was administered for the patients during the first day. And when we analyze the outcome for the fluid type, we can see that the 90-day mortality of balanced solution as well as the sodium chloride solution was almost similar, that is around 27%, 26.4 and 27.4. When the secondary outcomes were analyzed, it is also always almost all similar. And the subgroup analysis was also similar, except that for the traumatic brain injury, it is like the balanced solution has more mortality when compared to the sodium chloride solution. It shows that the sodium chloride solution is better when compared to the balanced solution for the traumatic brain injury groups. And regarding the fluid rate, for the primary outcome, that is 90-day mortality, it is almost similar. That is 90-day mortality for the slower administration as well as the rapid bolus administration is almost similar. And the selected secondary outcome was almost similar for this balanced crystalloid group as well as the normal saline group. This is just based on the fluid type, the primary outcome, no significant difference in 90-day mortality. And regarding the secondary outcome, SOFA score at day 7 was significantly different for the balanced solution group. The SOFA score for balanced solution group at day 7 was more when compared to the normal solution. And that may be because it has a higher neurological SOFA score of greater than 7 at day 7. And there is no statistical difference in the other 17 secondary outcomes, including the incidence of AKI with need of RRT within 90 days per 1,000 patient days. And regarding the fluid rate, when rapid with slow administration of fluid challenges were analyzed, the primary outcome has no significant difference in the primary outcome. There is no significant difference in 90-day mortality in the slower infusion group and compared to the higher infusion group. And secondary outcomes, just like the fluid type, SOFA score at day 7 was significantly higher for this balanced control group because of the higher neurological SOFA score of greater than 2 at the day 7 for the solution. And no statistical difference in the other 17 secondary outcome was found out. So when compared, when comparison was done between, actually this background of the study was the split trial, which is published in JAMA 2015. That is when they compared plasmolide 148 with normal saline in 2,278 critically ill patients, where the patients received 2 liters of fluid in each arm. The 90-day mortality, the need for renal replacement therapy, the need for the incidence of AKA, when everything was compared, there was no difference between the plasmolide as well as a normal saline group. And the other trial that was done regarding this was a SMART trial that was published in England Journal of Medicine, that is in 2018, where 1 liter of fluid was administered in each arm. It is found that the need for renal replacement therapy, the death and persistent renal dysfunction was more in the normal saline group. And the other trials were the FACEE trial that showed that the boluses, saline boluses or albumin boluses in critically ill children had higher rate of mortality when compared to the slow administration of fluids, as well as the FINISH trial that looks at the fluid bolus administration in over 2,000 ICU patients, which found that the practice of administration of fluids is variable in many ICU with regards to the volume, the rate, the endpoints of fluid resuscitation, etc. So the strength of this study is it is a large randomized controlled study, and there is good randomization, and there is better follow-up of the patient, and there is good statistical plan. And there are some limitations also. That is, 80% of the fluids received during the first days. Actually, there are some non-steady fluids also. The patients received some non-steady fluids also during their admission. So some contamination had also happened, and these could also make an effect over the analysis. So this is a large limitation. And there was fluid use prior to the ICU stay when the patient is in ED or when the patient is being when the patient is in surgery. Some fluids were used prior to the ICU stay. So these could have also made some effects. And there was post-randomization exclusion happened, mostly due to the lack of consent for the trial. Some patients didn't consent, so give the consent. So there was some post-randomization exclusion also that happened. And and many people, that is around 48% of people, were admitted after elective surgery. So they were not at all sick, and they were not at all requiring some fluid boluses also. So they were planned surgical admission. So actually these patients are difficult to monitor, and there is difficulty in analyzing their fluid responsiveness and to include these patients in the study group. And this study tested only specific balance solution. There are many other balance solutions also. So we cannot randomize this effect. And also, patients received a relatively small amount of fluid during the study. That is around median value is around 1 liter. So that could have contributed to the neutral results of the study. So these are all the limitations of the study. So the conclusion is, the use of a balanced crystalloid compared to 0.9% sodium chloride did not reduce the 90-day mortality. And the use of a slower infusion rates when a fluid bolus is required compared to the faster rate of infusion did not reduce 90-day mortality. The findings do not support the use of the balanced solution. Thank you.
Thank you, Dr. Sneha, for that good presentation. The session is open for questions. Anybody has got any queries? Sneha, what I could understand from your journal is there is no major difference in your primary outcome. What about the secondary outcome? Is there anything which is better compared with your balanced solution and crystalloid?
So when the secondary outcomes were analyzed, when the patients who were having traumatic brain injury, when they received balanced solution as well as normal saline, the patients with traumatic brain injury, they had more mortality with this balanced solution. So normal saline was better for them.
Okay. So, but there is no statistical difference.
Yes, sir.
No, not there. Okay. Yeah, I think Dr. Amir has got a question.
Yeah, thank you, Dr. Sneha. It was a really good presentation. Now I would like to welcome team from Narayana Hrudayalaya, Kolkata, to proceed with their presentation. Thank you.
Thank you, sir.
Good evening, everyone. I hope I'm audible and visible.
Yeah, you're audible.
Hello. Yes. Yes. Good evening, everyone. Well, it was an exceptional presentation both the team has done. So now from our side, Dr. Amir Jilani is going to present on a SMART trial. As we know that, we are constantly using fluids for critically ill patients in ICU as well as in the ER. So regarding that, the SMART trial, Dr. Jilani is going to talk about. Dr. Jilani, over to you.
Yeah, good evening, one and all. As I would like to special thanks to SEMI board and obviously Yashoda Hospital, and special thank to Dr. Lahiri sir, is the moderator, and to give me this opportunity to give talk on SMART trial. First, I'll say the SMART trial and the SMART ED trial, which is very similar study actually, which gives the very similar idea. But still, my topic is SMART trial. I'll give talk on SMART trial. So let's start with beginning from SMART trial. Is it visible to all?
Yes.
Yes, thank you.
Yes,
So
Doctor.
the contents of my topic will be from introduction, then I'll go with background, composition, study design, and outcomes like primary or secondary outcomes, result, conclusion, and finally discussion on that same topic. So SMART, basically what it is, the SMART, which stand for sequential multiple assignment randomized trial, which is based on basically two component of the fluid, that is balanced salt solution and the normal saline. So before that, we should know about the normal basics parameters and normal values of the electrolytes which contains the fluids. As you can see in normal saline, the osmolarity of the normal saline is 308 millimole per liter, which is a slight higher than the normal body osmolarity. That normal body osmolarity, we all know that it's around 275 to 295 millimole per liter. And you can see the sodium value is also little higher than the normal body serum sodium level. That is 54 millimole, and the chloride value is 154 millimole, which will leads to the hyperchloremic metabolic acidosis, which can cause AKI in the patient due to the renal impairment. And in the plasma light, the serum osmolarity is, as I told you, 275 to 295. It's very similar to the body osmolarity. So we basically, why we are improving we are suggesting the use of balanced solution, because of this component basis, which can help to the balance the body osmolarity and the body acid base balance. So coming to the introduction part, we always wonder about this question: ki administration of balanced salt solution and the saline, does it really reduce the 30 days outcome of the death or new renal replacement therapy or persistent renal dysfunction? Does it really helps to give the answer? According to the split trial data, as we can see, it's based on the 278 critically ill patient. The outcome shows there is no difference between two solutions to cause AKI or requirement of new renal replacement therapy or hospital mortality rate, as per split trials, and the hospital mortality, obviously. The the study design is based on the randomized control trial, pragmatic and cluster randomized multiple crossover, unblinded, and same fluid administrated done in the ED, which is basically the, if patient came to the ED, we supposed to start the same fluid till the patient got discharged, or till the 30 days of the admission. So we can really make a correct results of the trial. The study duration was actually done in 2015, June 1st, 2015 to 30th April 2017. The inclusion and exclusion criteria, in this we should include only that adult patient which is very critically ill patient is in ICU, or A should not be less than 80. A randomized population that studies was done on around 15,802 patients. The matching of the patient baseline along with the prediction. The baseline supposed to be similar. In this study, it shows that saline group and the crystalloid group, the risk of death it was 9.4% in saline group, whereas risk of death is 9.6% in the colloid group. And the risk of AKI developed in the saline group was 8.6%, and risk of AKI developed in the crystalloid group was 8.9%. So the outcome of this study was as primary outcome and secondary outcome. We can see on the base salt solution, the primary outcome which is related to MAC 30, that is major adverse kidney effect, which was shown as 14.3% in base salt saline, and the 15.4% in normal saline. Whereas secondary outcome in base saline, death was shown as 10.3%, as in normal saline it was little higher, 11.1%. The new RRT requirement in base saline was 2.5%, and in normal saline it was 2.9%. And the persistent renal dysfunction was in baseline is 6.4%, whereas in normal saline it was 6.6%, which shows like very similar difference, not much difference in both solution. The conclusion of the study was the IV balanced crystalloid over saline use decrease the disease outcome of the death and the new renal replacement therapy or persistent renal dysfunction at the days of 30. And in sepsis background, the base salt solution mortality was 25.5% versus 29.4% as in NS group. The strength of the study, the strength is very large sample size. We can compare the result. Is it audible? It's coming like connection.
Sometimes your voice is breaking off.
Yeah.
Yeah, coming to the weaknesses of these studies, as I told you before, it needs a multi-centric, multiple center, so we can find the actual proper results. But this studies was single-centric trial, and the long-stay patient may need chances of exposure to both type of fluid. So patient may get as per requirement of the patient that time, both crystalloid and normal saline due to the long stay. And the definition of the MAC 30 is different in this trial compared to the previous trial. As explained by the Ellen followed study, it was shown that the long-standing renal disease may decreases the renal eGFR by 20%. The treating clinician will not blinded element of conclusion and consciousness and unconsciousness bias. It may gives the bias results. and the plasma lights and ringer lactate trial does not still give the clear which one should be used by these studies. On the sepsis background, just generating the hypothesis because it does not provide the proper actually based on the sepsis patient what solution should be used. And the saline is better in patient with hyperkalemia. In these studies, they have shown that saline use is better in hyperkalemia patient because it contains more potassium. It may cause the balanced solution contain more potassium, which may induce hyperkalemia. But the fact is, if we are using normal saline 0.9%, what it will lead to? It will lead to increased hydrogen plus ion in your intracellular level, which will ultimately cause the hyperchloremic acidosis, and further it will damage to the kidney, which cause AKI. So exclusion of the patient in brain injury. Thank you. And any question, if you have, please ask.
Dr. Naveen, any question?
Yeah, as of now, no one has posted any questions. Guys, you can use chat box or Q&A section to post your questions.
I'll just say one thing, that one good part of this SMART trial is because they have included the medical ICU patients as well as the surgical ICU patients. So actually they have they have talked about both the medical and surgically ill patients. And though the results are not very conclusive, but there are multiple doubts that this trial has actually brought into. Like, we have a common notion of not using balanced salt solution in case of a traumatic brain injury patient or a kalemia patient. So should we really stop using balanced salt solution in those kind of patients, or can we actually use those kind of patients? Because the last study which Dr. Jilani has pointed out, that the ELAN study, where actually that they have pointed out regarding it is the reduction of EGFR. So
Yes,
I
sir.
think, yes. So I think, that is one aspect. We being an, ED physician, we should also consider, and we should also plan about something like this multi-center study of this kind. Over to you, Dr. Naveen. What is your opinion?
Yeah, in fact, these studies are, they publish very long opinions and all, and to have such a crisp opinion in span of like 10-15 minutes is, we are really thankful to those three teams, and each of you have presented the findings very well. So those studies, some of them have positivities and some of them were not so conclusive, but still we need to have that knowledge. So thank you very much to those three teams, the KIMS, Yashoda, and NH.
Thank you.
Thank you, sir.
Yeah, thank
And
you everyone for your contribution. I just want to conclude my opinion regarding these 3 trials. Okay, what I think is we need more multicentric studies in our Indian settings to arrive at a better conclusion on which fluid is better over other fluid. But most of these trials, what they have shown is IV saline and balanced crystalloids. There is no much benefit in non-critical ill patients. In critical ill patients with traumatic brain injury and hyperkalemia, there is some risk with balanced crystalloids. But other than that, there was no other much conclusion from these trials. We need more multicentric studies in our Indian settings to arrive at a better conclusion.
I'll just say one thing, Dr. Vishwa.
Yeah, sure.
Yeah. So, sorry to interrupt you.
Yeah, no, sure,
yeah. The thing is, the problem what with balance salt solution is compared to, if you see the price, actually, it is too much difference compared to a normal saline and
sure.
balance salt solution.
Sure.
So that is one point which actually restricts us to randomly use it.
Yes, sir.
So
very important in our Indian setting.
Yes, exactly.
Yes.
Very important for Indian setting.
Yeah.
Because in our hospital, actually, we thought about conducting a study like this. But then once we approach our committee, they were asking about all those financial aspects.
Yeah, definitely.
So that is when we had to came back. So that is one thing actually we have to think about.
Sure.
But as definitely as you told, it requires a multicentric study, and especially in Indian population.
Yes, sir. Yeah. Thank you, sir. Thank you.
Thank you.
It was a really good presentation from all the teams.
Thank you.
By this, we'll conclude today's topic. And I like to thank Dr. Naveen and Dr. Srinath sir for giving the opportunity for this presentation. And we hope to get more of these weekly webinars. Thank you, sir.
Thank you, Vishwa. Thank you, Naveen. Thank you, Shameem. Thank you, Lahiri, for participating in this webinar. It was a very good interaction between all of you. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.